Yes. Good evening, all.
Good evening, sir.
Good evening, all. On behalf of MAHA, I, Dr. Kundan Chopde, Executive Board Member, welcome you all for today's program. Today is the first episode of Subspeciality Spotlight, program of Presidential Action Plan of MAHA 2026. And today's spotlight is on pediatric cardiology. We are going to do Sri Ganesha of this Subspeciality Spotlight chapter on this auspicious day of Sri Ganesh Jayanti. So just I want to say Ganpati Bappa Moria and start the program. So I welcome all the office bearers of MAHA IP, EB members of Central IIP and MAHA IP, and today's all three speakers and all pediatricians who are joining us online on this Zoom platform and YouTube live streams. I am your moderator, Dr. Kundan Chopde. I am the course coordinator along with Dr. Bhupesh Bhon, and our program advisors are Dr. Nikhil Pathak and Dr. Ravindra Abbas Unone. So just I will like to invite Dr. Sanjay Doshi sir, the first elected MAHA IP president, for his opening remarks. Over to you, Doshi sir.
सगळ्यांना गणेश जयंतीच्या खूप खूप शुभेच्छा. गणरायाला वंदन करून आपण आज श्री गणेश करतो आहे सब स्पेशालिटी स्पॉटलाइट. So at the outset, I welcome all the OBs of Maharashtra IP, Dr. Renu Secretary, Dr. Amol, Dr. Vinayak, Dr. Mahesh, Dr. Sagar, and also the dynamic team of subspecialty group, Dr. Kundan, Dr. Nikhil, Dr. Ravindra, and Dr. Bhupesh. At the outset, I must express my gratitude to the subspecialty team, especially Kundan, for taking this initiative and arranging this webinar at a very short notice, since we all were busy in the Pedicon. So I welcome all the three young dynamo from the specialty of pediatric cardiology, Dr. Bauge, Dr. Parihar, Dr. Sugankar. In fact, when I was a resident, the book which I most like was Parloff, and it was like the echocardiography book for us. The hemodynamic investigation was so meticulous because in those days, to get access to the bedside echocardiology, so we never used to imagine, but even pediatric cardiologists were not there in the city of Nagpur. I am talking about the late 80s and 90s. So only our Bible was Parloff, and I don't know whether you all guys read, but nowadays I think the paradigm has shifted. Cardiology is more so of an imaging. Now we have it has advanced like anything, right from the 2D echo Doppler. Now we have MRI. So, without wasting much time, I welcome all my august audience who had joined on this virtual platform on behalf of Maharashtra IP, and signing off with this happy learning to all. Thank you.
Thank you, sir. And now I like to ask Dr. Renu Borakar, madam, first elected Women's Secretary of MAHA IP.
गुड इव्हनिंग वन अँड ऑल. नमस्कार. गणपती जयंती गणेश जयंतीच्या सगळ्यांना शुभेच्छा. डॉक्टर जोशी सर, our president, I also thank him for starting the session, and this is our second session in this month of the MAHA team 2026 with the lead of Dr. Sanjeev Joshi sir as the president. First was the masterclass in pediatrics that happened on the second Thursday. and now this has been done. And I congratulate Dr. Kundan and also the advisors, Dr. Nikhil, Dr. Sonone, and Dr. Bhupesh, to have this meticulously planned program at the 11th hour. And I am very much thankful to today's three leaders in the cardiac one, who are going to be the guide for us to for the suspicion which is there for the CH, heart diseases in our children, as well as with the diagnostic approach, the interventional and the case base. So I welcome on behalf of MAHA to Dr. Mahendra Singh Parihar sir, Dr. Pankaj, who is a very close friend of mine, and also Dr. Sangamesh. So it is a very great platform to interact with you all, and also all the delegates who have joined. I thank them to and welcome them to this program. Over to you, Kundan.
Yeah, thank you, ma'am. Dr. Amol, Dynamic Vice President, your remark, please.
Thank you. Thank you, Kundan. So first of all, welcome to all of you for this MAHA IP Spotlight episode number 1. Welcome all the experts, Dr. Mahendra Singh Parihar, then Dr. Sangamesh, and Dr. my dear friend Pankaj. Welcome all the office bearers, Sagar, then Sanjeev Joshi sir, Renu ma'am, this program coordinators, Nikhil, Dr. Ravi Sonone sir, then Bhupesh and Dynamic Kundan, and all the office bearers of Maharashtra IP as well as executive board members of Central IP and MAHA IP as well. So, as already sir has told and Renu ma'am has told, congenital heart disease is means when we suspect, common pediatrician, when we suspect, we straight away refer these patients to cardiologist, pediatric cardiologist, and then they they do 2D echo, and they very meticulously they do find the smallest whatever the defects and whatever the anatomy and all these things. So it is very difficult to diagnose, but still with their all weapons in their hand, they do this and they manage the tiny hearts very well. Because of them, the survival of these children is very much good, and long-term impact also on their life are very useful for child care. So once again, welcome to all the experts, and thanks Kundan for taking up this task along with Bhupesh, and you have to continue this task till December. So what means all the 4 or 5 programs are there, which will be which will run on every week. So those programs who run which run very successfully, they will be rewarded by Sanjeev sir and Renu ma'am and all the office bearers. So over to you. Thank you.
Yes. Dr. Sagar Balirao, sir.
Good evening, everyone. Good evening, everyone. It's a good thing that we are starting a subspecialty chapter. It is a reality. It's in today's world. We have much better results in the pediatric cardiology, and in subsequently month we'll be having all the specialty. In the span of next 12 months, we'll be covering all the specialty. It's a good thing that we are starting, and even in small cities now we are availability of the cardiologist, pediatric nephrologist is a reality. And all the best. Thank you.
Yes. So today's program advisor Dr. Nikhil Pathak and Ravi Sonone. Nikhil Pathak, sir.
So good evening, everyone. I welcome all of you. So out of the 3, Sanmesh I'm meeting for the first time. Mahendra I'm meeting every day. And Pankaj is my batchmate. So he does not meet me. So it's a good platform to meet him. Everyone on this platform, I welcome everyone. And let us hope that this series runs a good way and everyone enriches with the cardiology thing. Thank you very much.
Dr. Ravindra Sonone. So I think we will directly go to introduction part. Pallavi, madam.
Yes,
So
sir.
today's
Ravi sir, please. Ravi sir, please.
Yes.
Ravi sir.
बोलू दे
Yes, sir.
त्यांना, Kundan थांब.
Good.
Yes.
Thank you, Kundan. येतोय आवाज येतोय?
Audible, sir. Audible.
Good evening, respected seniors, dear colleagues and friends. It gives me immense pleasure to welcome all to MAHA's Subspeciality Spotlight Episode 1, focusing on pediatric cardiology, a field that truly represents hope, precision, and lifelong impact. I congratulate MAHA Academy for bringing this forward-looking subspecialty spotlight series, which will certainly strengthen clinical practice across our state. I extend my sincere regards to MAHA leadership, Dr. Sanjay Joshi sir, President, the first elected Maharashtra President, Dr. Vinayak Patil, President-elect, Dr. Sanjay Pakmode, immediate past President, Dr. Amol Pawar and my dear friend, Vice President, Dr. Renu Boralkar, Madam, Secretary, Dr. Mahesh Shahar Rao, Treasurer, and Dr. Sagar Valera, Joint Secretary Admin, for their vision and commitment to academic excellence. I also acknowledge and thank our National IIP Office Bearer, Central IIP Executive Board members, and MAHA IIP EBs, whose continuous guidance and support makes such a high quality academic initiative possible. And this today's session is in capable hands under the moderation of Dr. Kundan Chopde. And we are privileged to have an excellent panel of speakers. A special word of appreciation to our program advisor, Dr. Nikhil Patak. I am also a co-advisor with him. And the scientific team and coordinators, Dr. Kundan Chopde and Bhupesh Bond, for meticulously planning this program at such a short time. And I also welcome Dr. Sangamesh Bauke, Dr. Mahendra Singh Pariyar, and Dr. Pankaj Sugawkar, who will enrich us with real world interesting cases in pediatric cardiology. So I once again congratulate my IP team for the initiative and wish this series, Subspecialty Spotlight series, a great success in the years to come. Thank you all. I look forward to an academically enriched evening. Over to Kundan.
Yeah.
Thank you.
So we'll first introduce our all three speakers. So the program is that we are going to have first talk on cardiology by Sanmesh Bauge sir. That is the suspicion and diagnostic approach to congenital heart disease in pediatric practice. Our next speaker, that is Mahendra Singh Pariyar sir, will say about management and most importantly the timeline for intervention of congenital heart disease. We are very confused when to do what timeline we are supposed to do. And third speaker is Pankaj Sugawkar. He will share his interesting cases. Ma'am, first slide. Dr. Sanmesh Bauge. First one. So, Dr. Sanmesh Bauge is a pediatric and fetal cardiologist at Kokilabin Ambani Hospital, Mumbai. He is consultant fetal cardiologist and has 9 years of experience in the field of cardiology. He has done his UG and PG from Pune and super specialization in pediatric cardiology from Madras Medical Mission Hospital. He has done his fellowship in fetal echocardiography from Rainbow Children's Hospital, that is Rainbow Children Heart Hospital, Hyderabad. And he has also contributed in research work with international and national publications. Second slide, Dr. Mahendra Singh Pariyar sir. He is from Chhatrapati Sambhaji Nagar and he has done MD, DNB cardiology, FNB and PDCC, that is fetal cardiology. He is affiliated to various institutes. He is directed at Satyam Healthcare. He is director and consultant at Prime Healthcare Super Speciality at Chhatrapati Sambhaji Nagar. And he is assistant professor of Department of Cardiology, GMC, Government Medical College, Chhatrapati Sambhaji Nagar. And his team has done more than 6,000 cases of intervention and open heart surgeries, including neonatal and complex cardiac anomalies. And third speaker is Dr. Pankaj Sugawkar. He is currently the director at Little Heart Center, Pune, and Little Star Center at Pimpri Chinchwad. And he is also consultant at Ruby Hall Clinic and Sahyadri Hospital, Pune. He has done MBBS, DCH, FNB cardiology at Narayan Hrudayalaya, Kolkata. And most importantly, he successfully conducted the foundation course of pediatric cardiology across Maharashtra. And he has also, that course has been attended by more than 1,500 pediatricians all over the Maharashtra. So without wasting much time, I will request our first speaker, Sanmesh Bauge sir, to start with his topic. That is, over to you, sir. Sanmesh sir.
Hello, am I audible?
Yes, sir, loud and clear.
Yeah, thank you.
You can share your slides, sir.
So, my screen is visible now?
Yes, sir. Make it full screen, sir.
Just yes. Yeah.
Yes,
Yes,
perfect.
sir. It is full screen. Thank you.
So, good evening, one and all, at the all the office bearers, IP members, senior pediatrician, my pediatric cardiology colleagues. So, we'll be discussing today about how to suspect and pediatric the congenital heart disease and diagnostic approach to the congenital heart disease in pediatric practice as per the pediatric approach. So at the outset, I would like to comment and admit that the diagnosis of the pediatric cardiology, entire cardiology, is definitely not fully possible in the stipulated time of 15 minutes. So we will be trying to cover all the points, but we may miss, which we'll discuss in our some comments, questions, and discussion later at the end. So we'll be going through this topic in two aspects, like first of all, suspecting the congenital heart diseases and then the diagnostic approach. Suspicion in a clinical, like pediatric practice, we suspect by either by history, clinical suspicion, or the investigational clues, which we will see in details. Each one of these we will see in details. So first, clinical presentations. We all know how the pediatric cardiac patient presents to us, like cyanosis, cyanotic spares, and other features. But most important thing is how to differentiate whether this all the features which are present in other extra cardiac conditions also to from a cardiac angle, and to make it more clear that probably the patient is having cardiac disease than the non-cardiac disease. This is what we are going to see in all these individual points, like all these presentations, whether this is cardiac or non-cardiac. So each one, first of all, the first thing is you are able to see my slide entirely? Hello?
Yes, sir. It is visible.
Am I audible?
It is
Yes, sir,
visible.
it is visible.
Yes, sir.
Yes.
Visible.
So first point is like cyanosis, but visible central cyanosis. So how do we know that the cyanosis is cardiac related or non-cardiac? This is the first thing we should know. We should differentiate from the non-cardiac cause in a pediatric office practice. So any cyanosis which does not improve after oxygen or without any distress, like silent tachypnea, or without any respiratory symptom signs, should suggest that probably it is a cardiac cyanosis. The cyanosis generally presents when the saturation is less than 85. Above 85, it may be definitely missed, and may be missed in a patient who is a dark skin at our regions with severe anemia. If the saturation is between 85 to 95, patient will present generally with a gray tinge, not a clear-cut cyanosis, and may be very subtle. So therefore, point here being, we should always check a saturation. That also here shown like in a picture. The upper limb saturations may be normal, so we must check the saturation in both upper and lower limb. The lower slide and the left hand side corner, which shows that the first picture, which is showing the patient is normal. The second picture is showing the differential cyanosis. That means the lower half of the body is slightly desaturated than the upper half of the body. That is the differential cyanosis. Third is a reverse differential cyanosis, where the lower part of the body is slightly better saturated and then the upper half of the body. And the last one is the cyanosis in the entire body. So we should see the cyanosis as well as which type of cyanosis, whether it's a differential cyanosis, reverse differential. These all points are going to give us a clue to our diagnosis. So these are the some of the hints for getting a diagnosis to a congenital heart disease lesions. So first, this was the visible central cyanosis. So we should always check in upper limb and lower limb. Next thing is a cyanotic spell. Now, cyanotic spell is basically, we all know, probably the basic pathology here is the increasing right to left shunt across the VSD, which leads to some series of the events, and ultimately patient develops some signs and symptoms which is called as cyanotic spell. This is basically because of either due to reduced systemic vascular resistance or infundibulous spasm due to various triggering mechanisms. This is seen in TOF patient, and all the TOF, apart from TOF, it is also seen in a lot of other TOF physiologies, which include DRV, VSD, PS, and other physiologies. So TOF pulmonary atresia also sometimes, though there is a pulmonary atresia, it can also present with a cyanotic spell. How to differentiate now this cyanotic spell? Sometimes patient presents to us directly like a severe stage where patient will be convulsing, he will be cyanose. Now, how to differentiate these things from other causes like convulsion and the respiratory the cyanosis because of the respiratory. If you know the triggering, if you know the sequence of events in a cyanotic spell, like first there will be a triggers like early morning, some patient will be crying or defecation or fever, or the other triggers like patient after having bath or some dehydration. So patient will go on to hyperapnea, deep rapid breathing, followed by a deepening of cyanosis and tachycardia, and then the murmur will be absent during this time, leading to convulsion, irritability, floppiness. So if you know this sequence, we can know that probably this was not a convulsion followed by cyanosis or a respiratory thing with a cyanotic spell. Probably it is a cardiac related cyanotic spell. So it's very important. Sometimes we present at a later stage, probably we will not be able to see whether there is cardiac or non-cardiac. So sequence of event is very important. Next thing is the squatting and squatting equivalents. Obviously, patient who is like squatting equivalents are various, like sitting down with leg underneath, sitting with the leg underdrawn in a on a chair, or a leg cross, or holding the child with the legs flexed in a abdomen against the mother's chest. So obviously, this is a straight way we can see that probably it is a cardiac symptom. Another thing is a recurrent respiratory tract infection. What is recurrent respiratory tract? We need to define that. The currently it is defined as a more than 2 hospitalization in 6 months or 3 hospitalization overall. So it is a recurrent lower respiratory tract infection. If any infection, sometimes now we see that probably patient is not having entire pneumonia, but if he presents with a frequent respiratory tract infection more than 6 to 8, probably URI also during a preschool child, we may sometimes need to suspect probably there is a recurrent respiratory tract infection and probably having a child with a congenital heart disease. So it is seen in the left to right shunt, as well as sometimes if the cardiac congenital heart disease are associated with airway anomalies or the malnutrition, it may present as a recurrent LRTI. Next thing is a sucrase cycle, or in older patient, it will present as a dyspnea. So sucrase, like sucking or feeding is an exercise for a child. So therefore, sucrase cycle equal to exertional dyspnea in older children. So how do we differentiate the dyspnea of the cardiac and respiratory is very important, so that we can know probably all the patients presenting with dyspnea are not like cardiac, probably they are respiratory or cardiac. We can differentiate, like if the dyspnea comes first, then the cough or the respiratory symptoms, probably it is the cardiac. And if the cyanosis, event of cyanosis, if the first dyspnea and progresses to at later stage, probably it is a respiratory dyspnea. And if there is associated with orthopnea, PND, cardiac, respiratory examination will say that probably if the crests are more than the rhonchi, it will tell that it is a cardiac. Again, the examination by murmur or S3 will confirm that probably it is a cardiac, and X-ray will show the cardiomegaly. So, sucrase cycle, first patient feeds, gets tired, take rest, and then again breathes, and then feeds. So it is a sign of congestive cardiac failure, which is seen in the left to right shunt. Older children, it will present as a dyspnea on exertion. Failure to thrive, again, inadequate weight gain below 5th centile or crossing the 2 major centiles is called as failure to thrive. And it is due to the increased metabolic and oxygen demand, leading to increased calorie expenditure. On top of it, there will be decreased calorie intake because of poor nutritional absorption and the fatigue. Next thing is a pan-digital clubbing. If cyanosis, sometimes if the cyanosis is, the saturation is above 90%, we may not see the cyanosis. But therefore, if we have the clubbing, probably it will indicate probably.
मॅडम सरांचं काही हे झालंय
ऑडिओ आय थिंक
नाही
डोकं गरगरलं का तुझं?
मॅम त्यांचं ना हे आउट झाले, लॉग आउट झाले,
डिस्कनेक्ट झालेत वाटतं, आउट
डिस्कनेक्ट
झालेत.
झालेत,
ललिताचं
डिस्कनेक्ट झालेत.
डोकं गरगरलं.
सो
कुंदन
शुड वी
फोन
हो मी फोन करतो पण टिल
Dr. Mahendra, can you just start commenting what he is saying so we can interact? Unmute. Sir, unmute. Dr. Mahendra,
Yes, ma'am. Yes, ma'am. Good
Yes,
evening, ma'am. Actually, Sangmesh was trying to give about the profile about the symptomology of the pediatric cardiology. What symptoms we get the patient, and how do we suspect
right.
about the congenital heart disease? What are the recurrent symptoms when we need to have a suspicion about having congenital heart disease? The first of all, as he said about the cyanosis, most
Yeah.
commonly we miss the cyanosis when the range is between the 80 to 95, because to be a visible cyanosis the saturation has to be less than at least 70-75, so it can be obviously visible on your naked eyes. But as we know, post COVID era, everyone is using a pulse oximetry on OPD basis, so at least a simple pulse oximetry checkup of the patient can give an idea of having a borderline cyanosis between 80 to 95. That is one symptom. Recurrent symptom, as we all have been learning about the recurrent respiratory tract infections. Failure to thrive is the most common important indication to suspect about having congenital heart disease. What happens in most of the cases when we have an admixture physiology like your TGAs, TEPVCs, they won't have any clinical evidence of having a suspected congenital heart disease, but a simple having a saturation and high degree of suspicion can diagnose this patient early, because in this kind of patient operative outcomes are excellent and they have to go for the surgical correction as soon as possible. So that is most important symptoms or clinical finding to be having associated, because in a busy OPD practice we tend to miss this kind of borderline saturations. Other symptoms, what he said, that very obvious about the cyanotic heart disease, like your cyanotic spells, your squatting equivalents, your palpitation, as complete noticed by the parents, could we also have a high degree of suspicion when to refer this patient for the echocardiography examination or further evaluation. It could be your ECGs also in the elderly siblings or kids when we have a palpitation, so have the assessment of rhythm arrhythmias. The other symptoms like the palpitation is most important to have a diagnosis about the arrhythmias, because most of our practice on a training, arrhythmias are the most easily missed out. And in our team with Dr. Patak sir and all, we have been able to diagnose the arrhythmias in children, because for example, if you have a neonatal SVTs, patient mother, the symptom could be an irrelevant cry only. It's like the patient keeps on crying continuously. Mother notice something suspicious. When he goes to the pediatrician, he have a high degree of suspicion to have a SVTs basically, because in our unit at Aurangabad over here, we have been treating SVTs very often. Means like monthly we get at least 1 or 2 cases of neonatal SVTs and pediatric SVTs, which leads means like a simple adenosine injection, and your disease shock can revert them completely, and the ejection fraction also improves. So this kind of symptomology is also there. Though we have a routine symptoms like your recurrent respiratory tract infection, failure to thrive, high degree of cyanosis, but any unusual symptoms like continuous crying, irritability, means like the tachycardia, which is not explained by the clinical symptoms, we have to go for the other diagnosis also.
Right.
Echocardiography is basically nowadays easily available in all of the centers. A simple echocardiography examination can rule out the major congenital heart diseases, and the most critical ones. Like the critical ones are most important, because if we get them operated in time, they are going to have a normal life expectancy that we are going to discuss in my talk. But for at now, symptomology considering the high index of suspicious, failure to thrive, or recurrent respiratory tract infection for cyanotic congenital heart diseases, and always a cyanosis for cyanotic heart diseases. That is what he was
Yeah.
trying to explain.
Thank you, Dr. Mahendra. You have summed it up very nicely. And I think Sangmesh has been rejoined. So we will continue from his slides, which has been left.
Yes.
Yes. The most important point, Mahendra Singh has told that pulse oximetry. You can ask your receptionist to take out whatever you are taking, temperature, pulse. You just ask to add pulse oximetry.
Pulse
you
ox.
keep this pulse ox outside also. You will get diagnosis most of the time. It is not missed.
Definitely.
Sangmesh, are you able to share the PPT?
Yes, yes. Pankaj sir is there. Pankaj Sugawkar sir.
Pankaj.
Yes.
Yes. Can you have some comment on this, sir? Diagnosis and suspicion of congenital heart disease.
Actually, diagnosis and suspicion of congenital heart disease first is most important step of any diagnosing any heart disease or any disease in your pediatric practice is suspicion.
Yes.
But the suspicion has to come your mind. You have to have seen a lot of cases regarding it. The eyes will see, only the mind knows. So
Yes.
that the impression or importance of this seminar is for that thing. Hope after learning this seminar will raise the more suspicion. But I have seen most of the time, if the patient has recurrent respiratory infection, everyone thinks of left to right shunt. That is very common. When we hear the murmur, everyone think of congenital heart disease. That is the second most thing. Okay. Third thing is, if it is a cyanosis, everyone aware that it may be cyanotic heart disease. But some things with a saturation of approximately 85 to 95%, some heart disease can be missed. Okay, because each and every heart disease do not have a murmur, because in our mind every heart disease have a murmur. If it is no murmur, we do not suspect heart disease, but that suspicion should be there. I have gathered few of the interesting cases where heart murmur is not there, but there is a significant heart disease. Okay, so that is the most important thing. Do not label at murmur as a heart disease. If the murmur is not there, there should not be heart disease. It's not, dictum is not like that. So that is the most important step. And pulse oximetry should be in the routine, that as my dear friend Mahendra has said. And the suspicion, like how the dilated cardiomyopathy, how the metabolic heart disease. So you have to see in the picture. Whenever the baby comes to your OPD with the mother's lab, with the failure to thrive, if you are seeing the abnormal dysmorphism, if it is present, then you should suspect more of the heart disease type of them. Maybe another systems are getting involved. So first impression from the kit, our 50% diagnosis should be there. Okay, so that suspicion, that intelligence has to be there. I think we should apply in our regular pediatric practice. So if the baby has a lot of, I think the Sagmesh has joined it.
Yes. Thank you, sir. Pankaj sir. Very crisp. Sagmesh sir, you can continue your slides.
Sagmesh?
Hello.
Yes, sir. Audible. Slides are visible.
Yes, sir.
You
Yes,
can
sir.
continue,
Sorry, sorry for the. I don't know how it got disconnected from. It was login from my side. I don't know.
Dr.
Okay,
Sarve,
you
that's no
continue.
problem. You can
You
continue. It
continue.
is a
Yeah.
technical
You
glitch,
continue,
no
sir.
problem.
Yeah. So we're
It should
discussing.
happen once in every seminar. I think that is the good side actually.
That is the advantage and disadvantage of technology.
I don't.
Yes, sir. Continue, sir. Sagmesh sir.
Yes, sir. Yes, sir.
Sagmesh, can your slides are visible? Can you change the slides?
It's not moving. I will just again share and I'll.
Now, what you can do is you can click the share screen button and then go to
Then,
your.
yes, sir. Yes, sir. Yes, sir. Yes, sir. I'm doing that, but it's still not moving.
You minimize your presentation for now.
Yes.
Go to the share screen. There are lot of windows will be open from on your share screen. You can click your what is the expected presentation, and then you can continue from the current slide.
I'll disconnect first because it's not getting. I'll stop share.
Yes. Now
Again
you share
share.
the slides.
Again share.
Yes, sir.
Share screen.
You keep your PPT open so
Yes.
that will be shared easily.
Yes, sir.
Technology undergoing rest cycle.
Is it okay, sir, now?
Yes, sir. Skin is
But
sharing.
let me see whether I am able to.
Yes.
Make it full screen and start,
Yes.
sir.
Full screen.
Yes. Is it okay now, sir?
Yes.
So, okay. So we have discussed that how to differentiate respiratory and the cardiac dyspnea. Then we were discussing about the clubbing. So sometimes if you are not able to see the cyanosis, probably it's not normal saturation. Saturation may be low, which is not visible, but the clubbing will be there. So sometimes clubbing can be helpful for us to know that probably it is a cardiac patient. If not cyanosis, if the clubbing, sometimes without a normal with not normal saturation, like if associated with cyanosis, it more points towards the cardiac patients. So we should always look at both upper limb and lower limb, and it indicates the chronicity of the disease. Palpitation, the cardiac palpitations should be differentiated from the other palpitation. Probably if there is the associated chest pain, syncope, and if the patient is having palpitation after the exertion or sudden onset and sudden offset of the palpitation, it indicates probably the cardiac patients. If these points are not there, probably you cannot rule out the cardiac disease. Probably these points are helpful for going to, in more favor of the cardiac disease palpitation than non-cardiac. Next thing is a murmur. Murmur, it is a two-edged sword. What we were discussing, like Pankaj Sugavkar sir were telling, that probably absence of murmur does not rule out, plus presence of murmur does not rule in the cardiac diseases. So therefore, it is very important to differentiate between the inorganic murmur and the organic murmur associated with the cardiac disease. Inorganic murmur is generally soft systolic grade 1 or 2 murmur, which probably is changing with the posture without any thrill and radiating to some other area, and S1, S2 will be normal in that. So supportive evidence will be the patient may be asymptomatic with normal X-ray and ECG. Obviously, we will refer for sometimes for the echo. And organic murmur is like if the murmur is diastolic, definitely it is a organic murmur. Systolic murmur of grade 3 or more, or not changing with posture, with thrill, associated with radiation to other areas, and if the S1 or S2 is abnormal with it, definitely the murmur is abnormal. The murmur is cardiac murmur. So supportive evidence will be again the abnormal investigations. Physiological innocent murmur, there are two still murmur, which will be louder in supine and disappears on standing, or it can be a venous hum, which is seen in supraclavicular area, which disappears on turning hand and compression of the jugular vein or lying down. So another thing is a syncope. Cardiac syncope generally will be associated with the prodrome, like palpitation, shortness of breath, or chest pain, which may, if it is present in a supine position or after exertion, it is a cardiac syncope. And if associated with the family history, we should definitely see for the cardiac causes. And cardiac examination, if there is a history of a cardiac previous lesions, probably it is a cardiac syncope. On the other hand, non-cardiac syncope will be, there will be a prodromes, but the prodromes will be the like nausea, vomiting, or sometimes feeling of warm or sweating after a prolonged standing, or sudden change in the posture, like sudden from supine to sitting or sitting to standing, after a pain or dehydration, or during a micturition or some emotional stimuli. There will be absence of any family history, cardiac history, or the normal X-ray ECG. So this definitely does not rule out, but probably it will help in your diagnosis and to look into the matter urgently. Probably we should not miss a cardiac thing. So So again, family history, if there is a maternal history of congenital heart disease or antenatal infection or teratogens, family history of congenital heart disease or HOCM or palpitation, sudden death at younger age, also sometimes we should see to confirm, probably indicate that there is a suspicion, it increases the suspicion of the cardiac diseases. So this was about the history in very brief. So we will go on to the clinical suspicion. So clinical suspicion, first of all, appearance of the patient. If there is some syndromes, definitely it is associated, some syndromes like Down syndrome, Turner, DiGeorge, Allegri charge, all are associated strongly with the cardiac disease, so we should look for that. Extra cardiac anomalies like renal, CNS, GI will be associated with the cardiac, so we should also look for these during these patients. Pulse, if the pulse is feeble, femoral pulses, definitely it is suspicion of some obstruction at coarct level or severe AS. If there is a bounding pulses, it may indicate some large PDA or AP window or other runoff situations. Blood pressure should always check in right upper limb and the lower limb. Upper limb hypertension sometimes without a difference may suspect that probably there is a coarctation in older children, where there will be a collateralization of the upper and lower limb. There will be collaterals which will be supplying the upper to lower limb. So saturation we have discussed in detail. So if there is a left precordial bulge or hyperdynamic precordium, sometimes will indicate the so murmur. Again, absence of murmur does not completely rule out the congenital heart diseases. So if presence of murmur may indicate, but sometimes absence of murmur we rule out. That is probably a more problematic than making a diagnosis. Probably is having a cardiac cause. So absence of murmur should be correlated with the other things so that we can come to a diagnosis. Absence of murmur is absent in most of the 40% of the congenital heart disease like various TJ, IBS and other things. So it may be also masked in a neonatal PH or respiratory tract infection if the patient is having VSD and respiratory tract. Murmur may be absent during the spells also. Murmur may be absent. Very sick child, tachycardia, difficult to auscultate in a pediatric office practice. So another thing we can help to diagnose is in a neonate especially is a hyperoxia test. Hyperoxia test, how it is done? Cyanosis is confirmed by the arterial oxygen measurement. It will differentiate between the respiratory and the other causes of the cardiac lesions. The you have to administer a high concentration by probably by NRBM or a head box in a neonate for 15 minutes, and then you take a blood gas from right radial artery. So how do you interpret that? If the PO2 is more than 300, definitely you are not dealing with any cardiac or respiratory. If it is 150 to 300, it can indicate the pulmonary disorders and the other causes. If it is 100 to 150, the PPHN with other cardiac mixing lesion can be present. You may not be able to differentiate here between the two. Less than 100, definitely, probably there is a parallel circulation like TGA or cardiac mixing lesions with restricted pulmonary blood flow, like TAPVC. So it will also help in differentiating the and getting our diagnosis more towards the cardiac lesions. X-ray, how do you know that probably how do X-ray help us in our diagnosis in cardiac lesions? If there is a cardiomegaly in neonate more than 60%, infant 55 and more than 50% in older child. If there is an increased pulmonary blood flow, which is defined by a at least 3 to 5 end-on vessels, which may be visible, which may and there is a peripheral vascularity in lateral 1/3 also. So decreased pulmonary blood flow overall reduce blood flow to the lungs and pulmonary arteries, and their branches appears thinner than the normal, or there can be a peripheral pruning. These are various examples of the X-ray which may help. The first is a so now we define we need to group the patients into various physiologies, like not like VSD. We can call at this situation, at this level of diagnosis, we can call this as a post-tricuspid shunt rather than directly jumping onto a diagnosis. This is a post-tricuspid shunt, which was a VSD with cardiomegaly and increased pulmonary blood flow. Second is a post-tricuspid shunt PDA with dilatation of the aorta. Here there is a less dilatation of the aorta than here. The pre-tricuspid shunts like ASD, where this is the LV apex, which is the this is the RV apex, which is the upturned apex, and LV apex in VSD and post-tricuspid shunt like PDA is seen, while in ASD the upturned apex, which is suggestive of RV apex. Here all three X-rays are oligemic X-rays. First is a TOF with absent pulmonary wall. Second is the Eiselmenger, and third is a classical TOF, which shows a boot-shaped heart. So next thing is we should see out of the heart and the other markings so that we can see a diagnosis of a cardiac than non-cardiac. Like here there is a 3 sign which is suggestive of a coarctation. The X-ray here the situs inversus dextrocardia. Here we can see this is a case of a scimitar syndrome where we can see a scimitar sign and dextropose heart. Another here the aconside appearance of TGA. This is a classical X-ray of a TAPVC. This is the X-ray of a Epstein's with like decreased pulmonary blood flow and the cardiomegaly and the box-shaped heart. Next thing will be the ECG. So rather than knowing what are the abnormalities of ECG in our lesions, we should know first, if we know this is not a normal ECG, we can predict, probably suspect that probably may have a cardiac disease. So normal ECG sinus rhythm, where we can see the every P wave is followed by a QRS complex. the normal rate for the age, various the rate like various we have the rate as per the age. The normal p-axis, which is normal in the 0 to 90 degree, and qrs axis varies from -10 to 110 in various ages. So normal PR interval is 90 to 180 milliseconds. If anything abnormal, may suggest some cardiac lesions. QTC and isoelectric ST segments. So if you know the normal ECG, probably anything other than normal, we may suspect that probably there is a cardiac involvement. So like P wave abnormality, P pulmonary, P mitral, we can see prolonged PR or short PR interval, abnormal QRS axis, right axis or any left axis deviation, LVH or RVH with strain pattern, abnormal Q waves in V5, V6, and other things. So now this was about the how to suspect, where suspicion is very important. And then if we know probably we are suspecting a cardiac disease, we go on to how do we approach that cardiac disease. So approach, I would like to not go into the details of individual anatomical diagnosis, but we need to see what are the which group it belongs to. So cyanotic congenital heart disease, we have various physiologies. So we can put our patient into one of the physiologies. The first is a top physiology, where patient will present like cyanotic spell or squatting episode. What are the lesions it is associated? This is top with other top physiologies. So another thing is the transposition physiologies. How this patient presents? They present with a differential cyanosis without any spells. So these are TGA and Tausig anomaly who will present like a transposition physiologies. Other thing is the admixture physiologies, where you have uniform cyanosis. There is an admixture at atrial level or ventricular level leading to uniform cyanosis without any spells. These are TAPVC, common atrium, tricuspid atresia, other single ventricle. Duct dependent lesions, systemic and pulmonary duct dependent lesions, where you have differential or river differential cyanosis in a systemic, and pulmonary duct dependent pulmonary circulation, you have uniform cyanosis plus minus spells, or there will be desaturation. So systemic circulation dependence will be by PDA will be severe AS, coarctation or interruption of aorta in HLHS, and pulmonary circulation there will be critical PS, pulmonary atresia, wherein like top pulmonary atresia, tricuspid atresia with pulmonary atresia, or intact ventricular septum with pulmonary atresia. So another physiology is Eiselmenger physiology, where the symptoms of increased pulmonary blood flow there will be there initially, followed by symptom free period, followed by a cyanosis, and this is seen in left to right shunt at an older age. So this was about the cyanotic heart diseases and their various group of lesions and the physiologies. Next is the acyanotic congenital heart disease. It can be grouped into post tricuspid shunts, that means below the into the ventricle at the level of ventricle or the great artery level. Like they will be presenting at early at 6 to 8 weeks or 8 weeks to 3 months, and they will be presenting like a suppressed cycle failure to thrive recurrent LRTI. It will be seen in VSD, PDA, AP window, and AVSD. Pre-tricuspid shunt, they will be presenting late with failure to same symptoms, but they will be presenting late, or they may present with the dyspnea like ASD and the hemianomalous pulmonary venous returns. So another are the obstructive lesions, like left-sided obstructive lesions, right-sided obstructive lesions. The mild to moderate, they may present with the murmur. Serious cases, left-sided obstruction present with syncope and dyspnea. Mild right-sided obstruction will present with the murmur. Moderate to severe will present like fatigue. So another next thing is the regurgitation lesions, which will present like as a palpitation, which will be mitral and aortic regurgitation. There are other things which will not be classified into anything, like Alcapa, inflow obstruction, scimitar syndrome, etc. A lot of things are there which may not be grouped probably into anything. Sometimes by age of presentation, we can see that probably if it is presenting at birth or within 24 hours, where probably it's not so much dependent on duct like admixture lesion, probably obstructed TAPVC, TGA with intact ventricular septum with the transfusion physiology. Also the Tausig anomaly with unfavorable streaming, where it behaves exactly like TGA, may present at birth. Next at neonatal age, which will be determined by closure of the PDA. So therefore duct dependent systemic and pulmonary circulations may present that time. Neonatal the coarctation also can present that time. Next is a 4 to 8 weeks, where post tricuspid shunt and the Alcapa may present, where the PA like the transition, the PA pressures fall and the patient becomes symptomatic. 6 to 12 weeks, the TOF and TOF physiologies may present. During 2 to 10 years of age, very wide range. So the Eiselmenger syndromes depends on the, it varies from which age Eiselmenger rises. So Eiselmenger syndrome in post-tricuspid shunt, coarctation can present at any age, and also the valvular stenosis can present at 2 to 10 years. Adolescent, the coarctation again can present. The second and third decade post-tricuspid shunts are present. Though this is a general guideline, it's not hard and fast that probably during this age line, the timeline the patient may present, but it's generally we can suspect which lesions can be presenting at this what age. And I think, thank you. I would not have covered everything, but I tried to.
Yes, sir. Thank you, sir. You have covered in depth and in detail. I think so that all pediatricians should be how confidently now suspect and diagnose the congenital heart disease after your presentation. We will next move to our next topic, that is management and timeline of intervention of congenital heart disease. I would like to ask Mahendra Singh Pariyar sir to please share the slides. And
Yes, sir.
Yes, sir. Over to you, sir.
Yes. So just 1 second. So he has to stop sharing, I think.
Yes,
I'm not
yes.
able to.
Sangmesh sir, you stop the screen sharing.
Can I
Sir,
ask one query, Sangmesh?
I have
Yes.
stopped the
Sangmesh, can
sharing,
I
sir.
ask one query?
Yes, sir.
Yes, sir. Yes,
Dr.
sir.
Mahendra.
Yes,
Till
sir. I
Dr.
Yes,
am
sir.
Mahendra
good evening,
share.
sir. Yes, sir.
Please, sir,
See,
please, sir.
you have talked about the hyperoxia test.
Yes, sir.
I think there is a very good paper from my mentor, Dr. Martin Kluka from Sydney,
Yes, sir.
about the identifying critical cyanotic disease by just pulse oximetry scanning.
Yes, sir.
Once after the 48 hours, when the transitional circulation settles in, the paper says that you do pulse oximetry in four leads. If at all the values are around 85 or 80 or 85, you just repeat after 12 to 24 hours. So you can exclude the critical cyanotic congenital heart disease almost up to the tune of 90%. What is your take? Anybody can take this.
Yes, sir.
Rather than hyperoxia or something like that, we do a lot of neonatal screening nowadays. Why not to do this screening also to rule out critical cyanotic heart diseases right at a day 3? Right, at least those can be those babies can be put for further evaluation.
Yes, sir. Definitely, the hyperoxia test is just all these things which we have discussed is just if it is positive, then it's okay. Just is for differentiating between the definitely normal pulse oximetry screening in all the patient by guidelines by American Heart Association, which is given. We should do that. Plus, if you are suspecting a cardiac disease, sometimes this hyperoxia may differentiate. Sometimes, if you are not having able to get a pediatric cardiologist, if you have seen that probably it is a responding to oxygen or something, probably you will see that probably it is PPHN.
Okay.
If you're not, it will help in that scenario. Otherwise,
Thank you.
it's just a guide.
Thank you.
Yeah.
Let's start, sir.
Yes, sir. Mahendra Singh.
Yes, sir. So, good evening all for the topic presentation. I was allotted with a topic called Management and Timeline for Intervention in CHD. So, after a elusive talk by Dr. Sagmesh, my job in this presentation is to guide all of you when to refer patient, how to counsel the parents, and just give a rough idea. I'm not going to go into most of the depth, so it could be quite confusing for all. But my idea is to know that at least you all of you could have some idea that when to refer, what are the guidelines when we intervene the patient, when to not, and when should we be quick in our decision making. So the roadmap for my talk will be, I will quickly go through about the introduction of the congenital heart disease in our country, the facts and the scenario in our country, what we are facing right now, what is the timing of intervention in cyanotic heart disease and in the critical cyanotic heart disease. What are the recent heart failure updates? Means like it's not only about operating the patient, but sometimes we have to go them for anti-failure medication and what we have in the new drugs been included. And quickly we will conclude the session in the end. So to introduce, We all know that we have been facing and we have been seeing the patient with congenital heart disease, but the importance that it contributes about 35 to 40% of all congenital defects at birth. And the incidence in overall incidence about the critical or the moderate to severe congenital heart disease goes from around 0.8 to 1.2%. That means like out of 100, one baby has a critical cyanotic heart disease or critical congenital heart disease. But if we include the minor defects or the benign defects like your bicuspid aortic wall, smaller ASD and smaller VSD, the incidence is quite big and it goes up to 10%. And when we have a family history or any syndromic children, the incidence increases significantly up to 50%. So what is happening in India? As per the data collected by the different agencies, they say that every year 2.5 lakhs children are born in India with a critical congenital heart disease, which approximate about to 1/5 of the global burden. And out of that, 35% die before their second birthday. And it is a major contributor for under 5 mortality. So as a IAP action plan, and this is one of the most critical disease that we can treat very easily. And so we can have a long-term survival. So any present time in India, around 25 lakh children needs any kind of intervention or surgery for the congenital heart disease. And only out of this, 50 to 60,000 received their first consultation. Until now, we have been operating only 15,000 cases all over India. So it includes that we have been a part behind in providing the topical care for this patient. So what is happening nowadays, if this patient becomes unrepairable or they don't go anywhere, they go into adulthood. That's how. So just a quick slide from WHO, what they say, approximately every 15 minutes, one child is born with a critical heart disease. But in our country, that it has been neglected. There is a high prevalence, but it is underfunded also, because what we have been able to treat is mostly in the private setup, in the corporate setup. Government hospital setups are far behind when taking care of this kind of children. So the picture to my right shows what is happening in congenital heart disease. As I already said, there are more than 2 lakh children born with a congenital heart disease, and more than 70,000 need any intervention need at given point of time. But we are very underfunded for that. So soon we too see the patient who are in a grown-up congenital heart disease because they remain unrepaired due to negligence, due to be under counseled by the our treating fellows or something like that. Or they can be operated and they have a different physiology when they come into the adulthood. So typically now we are seeing something called as a GUJ, which is a term for the grown-up congenital heart. So it could be unrepaired and repaired both. So just to give a quick review that not in our setup, but in Australian countries and Western countries, the repaired heart have a major contributions. And even if these two cricketers, they've been operated, the bowler from the Australian has been operated for tetralogy and early hood, and he has been played for Australia. And the other one, we know that he has been suffering from, he was operated for ASD and atrial fibrillation. So he's still playing a great cricket for all of us. So why it is important? Because as we compare data from different studies, they say once the patient goes older, there is an increased survival. So when the patient was, this slide shows what has been happened from 1980 to 2017, that we have increased survival. This violet line in the up so that when the patient has been operated for more than last 10 years, the survival has been definitely increasing nowadays. So this is a slide shared by my surgical colleague. He says that what makes the difference for a surgical operator. When we operate the patient with cyanotic heart disease, the survival is as compared to your control population, but it has to be at the right time for them. So now quickly going about the intervention. So we all have been learning this chart since MBBS days, that how we differentiate the cyanotic heart diseases. So it's a quite lengthy chart, but my part is today that I'm not going to focus all of this. My idea is to give quick review about how what is the intervention timing for the atrial septal defect, VSD and PDS. Obstructive lesion, because they are the critical and most efficiently could be treated adequately, like your pulmonary stenosis, aortic and coarctation. And for cyanotic heart disease, I'm going to restrict my talk about the tetralogy of Fallot, because none of them others, they have a typical intervention. So in our office practice, this 5 to 6 diseases are most efficiently could be treated. So coming to the first, that is atrial septal defect. We all know it contributes about 15-20% of all CHDs. Most common is ostium secundum. A rare one as ostium primum, sinusonosis, and coronal sinus defects. It is usually diagnosed as an incidental finding in childhood. Most of the children that we came as a refer that they go to their pediatrician, they suspect they have a audible murmur, and they came. So most of the ASD patient has been diagnosed around the age of more than 5 years for them. And symptoms may develop as the age advances when they enter into their 20s or 30s, and atrial arrhythmias are contributing more than 40 years. So we have been in this part of India, we are still seeing the patient who have been elderly, about 35, 40, and they come to us with a diagnosis of ASD. So daily we can say at least one patient who has been adult congenital heart disease. So ASD is most common among them. So how to differentiate and how to counsel the patient? So when you have a echo report and they say ASD, which is less than 4 it is considered as a benign defect. It is a small defect. We no need to intervene for this, and we just have to keep on them continuous follow. So when the defect is between 4 to 8 we need to close this up. So how do we counsel when the defect is less than 4 we don't need to have a worry about this defects. We can just follow them yearly. 4 to 8 ASD, they have to be on the routine follow. They can get close or may not get close around 4 to 5 years of life. So that how, but any defect which is more than 8 they will definitely get a closure. They will need any kind of electro intervention. So for now, it just to remember that when the ASD is more than 8 it is a larger defect. We have to counsel the parents that they will need an intervention, so they could be ready for that, so they don't miss out that. So as a natural history, what they say, above 8 it rarely closes, and after 2-3 years we rarely found any closure of atrial septal defect. And out of this 14% of patients, the larger defect can have a complication like Eisenmenger, and they could also have arrhythmias later life. So for now, when we have planning to close the ASD, it is mainly after 3 years of life, and ideal age is 4 to 5 years of life. So any ASD should get treated by 5 years of life. That is dictum, because this is a preschool age. They can have adequate rest and patient can be followed. So the two types of techniques are there, as we all been learning, that it could be a percutaneous device technique or it could be open heart surgery. Percutaneous device technique is mainly used when we have a second type of ASD, and it is contraindicated other type of ASD like ostium primum and sinus venosus. But we don't need to have the defect in a central with adequate rims, and there is no any evidence of pulmonary hypertension for us. So this is how, just to show a slide, this is a defect between the interactal septum, and which can be easily put a device and get it closed. It looks like a dumbbell-shaped device. The other technique is basically surgical techniques. So it could be done by your CVTS colleague, it could be done by a sternotomy, but now the advances are been there, so we don't have to offer this ugly scars nowadays. The sternostomy scar, the most of the dreaded complication for open heart surgery, why the people defer that is mainly because of the scar, and mainly in the female population. But with the evidence of technique, we can have a minimal scar, which is not very ugly. And we can also have other kind of techniques like using a minosternotomy or thoracoscopic also evidence. So whenever you want to get a ASD closure, try to get it closure by below 25 years of age when the PA patients are normal, because when we have a age advancing more than 3 decades of life, the survival benefit is not there, and patient could have been remain symptomatic, and they could have arrhythmias. So this is from our center. We try to get close when the patient is more than 20 kg by thoracoscopic approach, which is basically equivalent to a laparoscopic surgery. So the patient don't have ugly scars on their sternum, but they could have a minor scar on their lateral wall chest. And other techniques like your mini sternotomy below breast scar could also be easily accessible. So just to an idea that most of the people have that mindset that a scar could be ugly, but nowadays the technique has been advanced and we can offer a minimal scar as compared to a other sternotomy scar for the patient. So the defect that I'm going to discuss about a ventricular septal defect, we all know that is a perimeminal is the most common type. Other defects like outlet VSD, inlet VSD could also be present. So what the guidelines say? Now, most of my talk has been exploited from the IAP guidelines that we formulated 5 years back. And it has been from the extensive data that has been studied at AIIMS Delhi and other major centers. So what they say that all one class 1 recommendation are for that when we have a smaller VSD, that means that we don't have a patient with the symptoms of any CHD, normal PA pressure, any normal heart size. So this patient can be followed up to 10 years of life. and then every 2 to 3 years. So not every VSD need to get closed. When we have a defect less than 3 mm and patient is don't have any kind of symptoms for that and patient is growing adequately, though we don't want to intervene in each and every VSD. We can just keep them and follow and ask to them in follow, because they are not very hemodynamically insignificant for us. Moderate VSD, then when the patient has quite symptoms, they have a symptomology, they have a evidence of recurrent respiratory tract infection, fail to thrive. Elective closures, if the patient is asymptomatic, 2 to 5 years of life. If the patient is symptomatic, we can get closed by 2 years of life also. Most of the talk, I would like to emphasize that most of the CSD has to get treated by 5 years of life. And when we have a larger VSD, when the patient is quite symptomatic, failure to thrive, recurrent respiratory infection with evidence of CCF, we have to get them treated as early as possible. But if we have a controlled heart failure, we can treat them at 6 months of life. Why 6 months is important, I will tell you in my subsequent slide. So just to recap, VSD can get closed by after 6 months of life, and ideal which is around 6 kg. If a VSD is small, we can wait up to 12 kgs also. And many of the devices that we use as an interventional cardiologist, it could be a PTA device closure. We have a lot of multiple size and combination of the devices that we choose upon the evidence of VSD. And other option, there it could be open heart surgery. So just a slide to show then this is a 4-chamber of heart. We can see the defect in the interventricular septum defect over which get evident the color Doppler. And when we put a device, it get completely closed. So this is again like a scarless surgery for the patient, and the patient is symptomically much better. Now, why I'm emphasizing around 6 kg of life, when the data was studied from different center, they have to find out when the patient gets operated below 4 kg or 5 kg, the complications and death after surgery is quite high. But when we approach to the weight of 6 kg or around 6 months of life, the risk is minimum. The patient can tolerate the surgery, the longer surgery very well. So 6 kg and 6 months is the time frame for VSDs. Now, the most common that we face each and every day is patent ductus arteriosus. PDA is a connection between your pulmonary artery and the aorta, which has been patent from the fetal circulation. Smaller defects, which are very generally asymptomatic, can be ruled out and just followed as we did for the ASD. But the larger PDAs, which are like patient is quite symptomatic with a frequent respiratory tract infection, failure to thrive, and CCF, we need to intervene. The quick remark about the preterm babies, they are very tiny babies, and we have a typical history that there is a typical deterioration around up to 4 to 7 days of life when the PDA reopens, and there is an increase of gush in the lungs, and patient present with the CCF. So what is the indication of PDA treatment for any baby in ICU when the baby is symptomatic? When an echo report says that PDA is there is a LA evidence, LA and LV is enlarged, or we have a ratio called as a LA outer ratio, or any preterm who has a hemodynamically significant PDA with evidence of CCF, prolonged respiratory support, unexplained O2 requirement, or recurrent apneas, we need to go for PDA treatment. But however, there's a word of caution. When we have a respiratory pathology like your RDS, your pulmonary hypertension, we should wait not to close for the PDA, because this could be detrimental for your patient. And when we suspect a PDA dependent circulation, it would be a systemic on PDA, then the PDA is a lifeline for the baby. So for PDA treatment, you need to be very aggressive. The general measures includes to importance of the HB monitoring, fluid restriction, inotropic support. Generally not recommended, but we can manage if required. Diuretics for to make the patient negative, and your mechanical support. So the drugs, as we know, we have been using the paracetamol nowadays. Means last 1 decade, everyone has been shifted to using the paracetamol, and ibuprofen as mostly importantly when the second dose. And indomethacin, though it has been given in our literature, but it's hardly available in our country. So what we do with the PDA, when we have a preterm PDA, we have to intervene if there is evidence of heart failure, which is a class 1 indication. Approved drugs from the Indian IAP is mainly indomethacin, ibuprofen, and paracetamol nowadays. We can go intravenous or oral, depending upon the clinical scenario. And if this all fails, we can go for surgical correction or intervention. But prophylactic indomethacin or ibuprofen is not recommended by IAP for all of us. So what in our center we practice, when we have a patient, the preterm baby, the persistent PDA or reopening of PDA with symptoms, we go 2 courses of the oral medication. It could be either paracetamol or ibuprofen, or it could be alternately, but we generally have a practice to follow paracetamol first. If the PDA doesn't get close, we give ibuprofen orally for that patient. And still we have a symptomatic PDA or hemodynamically significant PDA, then we think about the intervention of consider as a failure of medical therapy, and we try to close that PDA. So cardiac intervention is mainly a reserve strategies for the PDA when we have a failure of medical therapy, or if we have a contraindication to medical therapy. It could be again your device closure and surgical ligation. With a recent advance in the availability of piccolo device, which is a very tiniest device, which could be just like half of your nail bed, we can get close this PDS as soon as possible. So the PD device closure technique has been seen. We can see that when we have a duct between the aorta and the pulmonary artery, we can get it closed by the two device adequately. So the next lesion I would to like coarctation, because coarctation I will like why it's important, because it's a narrowing of the proximal aorta and maybe have a longer tubular narrowing, and it could have a poor prognosis. When the patient comes to us in adulthood, it's quite difficult to manage them, and they could have a premature coronary artery disease or aortic aneurysm, which could be detrimental for them. And why it's important, because it could be clinically easily picked up. So my talk and my point of highlight is we always have to palpate the lower limb pulses for your patient. Most of the pediatrician in office practice have the patient who's been lying down in front of you on your couch. So my just point of emphasis is that instead of palpating your radial pulse, if you have a practice to palpate the dorsal pedis, you can easily diagnose a coarctation. Because what we are seeing in our practice, that most of the patient, they have that idea that we have been visiting the pediatrician, we have been visiting the multiple practice, but none have given a chance that the patient has a coarctation, because coarctation can be easily missed, but it has a detrimental effect in adulthood. So my point to advise is to just, we need to advise and palpate the dorsalis pedis or femoral whenever possible to diagnose a coarctation. So ideal age for intervention, when we have any evidence of a LV dysfunction, congestive heart failure, or severe hypertension, we have to intervene as early as possible for any age of the patient. When we have a normal LV function, no congestive heart failure, normal blood pressure, we can intervene around 3 to 6 months of life. And when we have a elective patient, we can wait for 1 to 2 years of life. So what we practice in our setup or in our unit, and when we have a neonatal coarctation, we look for the anatomical anomalies like aortic arch hypoplasia and LV function. If aortic arch quite sick, he's quite in a dysfunction, then we have to go a bailout strategy for going for the balloon dilatation, so we can go for the patient to go for the upcoming surgery. But when we have an infant who have a native coarctation or recoarctation, we can always have a choice between a surgery and a balloon coarctation depending on the scenario. But when the patient is older kid and less than 25 kg, we can just put a balloon and dilate that coarctation segment. But when we are adult, we can put a stent also. So just a quick how we do it. This is an interventional technique. Then when we have a discontinued aorta coarctation, we can just put a balloon and dilate that segment so the patient can be adequately handled. So coarctation always need a correction. We have to look for the symptoms, cardiac and hypertension, and we can go for balloon dilatation or surgical correction possible. Obstructive lesion, it could be a aortic and pulmonary stenosis. So it could have an obstruction above the valve. It could be supravalvular stenosis at the valvular level and the infundibular at the subvalvular level. Again, the categorization could be mild, moderate, and severe. So for indication, when we have a symptoms, it could be of fatigue in a case of aortic stenosis or syncope in a case of aortic stenosis. Then when we have an echo report showing a severe stenosis, we can quickly go and decide about the intervention. Or any evidence of cardiac dysfunction, any obstructive lesion, it would be a aortic stenosis, coarctation. Any heart failure is a timeline for to go for the intervention as soon as possible. And balloon valvotomy for the valve only is approved. For if we have a supravalvular and infundibular, surgery is a treatment of choice. So this is a balloon dilatation of pulmonary valves. We can put a balloon across the valve, and once the balloon gets inflated, we can see the vest disappear for us. Similarly for the aortic balloon dilatation also. So we just have to go for the intervention. Balloon technique is quite simple and easily available nowadays. So what about a complex or cyanotic heart disease? I'm just going to talk about palate physiology. We all know it has a four components: VSD, RVH, and pulmonary stenosis. Why it have a variable RVO2 obstruction, and also depends on the anatomy. A quick remark about the cyanotic spill: we have to maintain the hemoglobin more than 14, and we have to give the beta blockers at the possible tolerable doses, which could be 1 to 4 mg per kg per day of metoprolol or the propranolol. And for surgical correction, when the patient present to an early infancy and the saturation is less than 75, we go off for early palliative surgery, which could be a systemic pulmonary shunt, that is a BT shunt. Sometime we can afford we can pose the patient for PDS stenting. The PDS still pattern, RVOT stenting is possibility, and also the balloon dilatation of the pulmonary valve. But when the patient is beyond infancy or more than 6 kg, total correction, that is open heart surgery, is always indicated, because if we correct the patient by 1 year, patient has a normal life expectancy. So just a simple diagrammatic representation. When we have a connection between the aorta and the pulmonary artery is a BT shunt, another one is a total correction. So just in short and crisp, when we have a cyanotic heart disease, ASD, preschool age, that is around 3 to 5 years, we have to treat the patient. Large VSD, around 6 to 12 months, moderate VSD, 1 to 2 years, and small defect, 3 to 5 years. And PDA by 6 months, 6 kg. 6 is the rule for our setup. For cyanotic CSD, top physiology, ideal is around 6 to 8 kgs of weight, or the palliative surgery of infancy. And any complex CSD like TGA, TPVC, truncus, anything beyond that, we have to go at the earliest as possible, or when the diagnosis has been done. So just a quick reminder, what about the heart failure therapy? We all been practicing using the furosemide, enalapril, and all your digoxin. But just a word of caution, by this, what we have been now, digoxin is not a proper indication to be started in a patient with heart failure. When we give a cardiac glycoside, digoxin is a 2B indication. So one indication is mainly your ACE inhibitors like enalapril and your diuretics. The other drugs which have been coming is like your beta blockers, SGLT2 inhibitors, which is basically anti-diabetic drug, which we have been using in our unit about 10 years of life. Like when we have a patient with a CCF and more than 10 years, we are using dapagliflozin RNA, that is a neprilysin inhibitors. They have a better survival for this patient. So that's from my side. Concluding in the end, congenital heart defect has an excellent post-operative result. Good survival with a normal life expectancy is there in the present era. Timing matters. For now, most of the time has to get repaired by 5 years of life, and adequate preoperative care matters a lot. So just a suggestion, if we have a time, you can go about this recent guidelines published by Indian Heart Journal, that is 2025 heart guidelines, and also the medication of pediatric heart failure practice. And our IAP also has given a guidelines about the Indian guidelines when to operate and intervene about a CHD. It is a very good guideline, Chris, not much, around 7 to 8 pages, and it gives what to do when we have a CHD, and also the American Heart Association guidelines. That's all from my side. Stay safe. Thank you for patient listeners.
Thank you, sir. You have covered the topic well in a practical way, and I am confident that all pediatricians know when to refer patient to pediatric cardiologist, because after diagnosis you have to refer patient, and timeline you are told exactly. So without wasting time, I will ask Dr. Pankaj. Can you stop the screen sharing, sir?
Yes, sir.
Yes. Dr. Pankaj Sugavkar, he is going to show the interesting cases in pediatric cardiology. We have covered the theoretical part of clinical diagnosis and suspicion and when to intervene. Now, the case-based approach is very important, that is easy to remember. So, Pankaj will share some interesting cases in pediatric cardiology. Over to you, Pankaj. Yes. Yes, Pankaj, your video.
Yes, am I audible?
Yes, yes, loud and clear.
Yes, thank you so much. I know that it is already 10:20 and I'll keep these things in my mind. So thank you so much, my colleagues, seniors, and my friends, Kundan, Nikhil, Renu madam, and Joshi sir. And it's a wonderful discussion from my dear friends. So today I'm discussing about the interesting cases in pediatric cardiology. So it is a 10-day-old baby, which is a tub baby, which is unexplained respiratory distress. Okay. So I will not put a lot of things into the action, because unexplained respiratory distress means it does not have any problem like infection, other things, no other issues, no congenital heart disease at all, like cyanotic heart disease or acyanotic heart disease, but something is abnormal than the normal. It is that we did his echo, it's found to the double aortic arch. So vascular abnormalities are very common in newborn period up to 3 to 6 months of age, that we should not miss it. Okay. So we did CT scan. What is the need for CT scan? Because it is a double aortic arch. One arch comes from the right side, one arch comes from the left side, and they compress the trachea. And that's the reason the patient do not come from the ventilator. and the patient have a recurrent cuff cold. So we have seen approximately 6 to 7 cases of double aortic arch where the surgery has been advised, and some cases of incomplete arch, or that is called one dominant and one non-dominant arch, requires some surgeries. So in a term baby, unexplained respiratory distress, baby still on the ventilator, unexplained cause, please do the echo to see not for the heart disease, but for the vascular abnormalities that can be present in the child. So that is the inference from my first case. So here is a normal aortic arch that you can see come from the front. Double aortic arch, one come from the back and another come from the front, and it compresses the trachea, and it is a right aortic arch. Okay, so that's how our three arches are comparatively different in nature. So another diagnosis, that is vascular sling. Sling means the LPA coming from the RPA, not from the MPA bifurcation, and sometimes it compresses the one bronchial this thing and causes a compression, causing the recurrent pneumonitis, prolonged pneumonitis, non-explained consolidation, non-resolving consolidation of the particular lung because of any other, not because of any other reason. You should suspect any vascular sling from the cardiac point of view. Then this is the second most case that we have seen. 8-month-old patient came with the cyanosis respiratory distress. He was having a fever, cough, cold. X-ray shows a mild cardiomegaly. Saturation is 50%. No difference in upper and lower limb. Echo is normal, no CSD. So then what is the diagnosis? So echo is normal. Everything is come to this thing. So we send his methemoglobin levels, and methemoglobin levels come to the 29%, and we are given the IV methemoglobin blue, and the patient improved within the next 3 days. So if it is unexplained cyanosis without any reason, no structural heart disease, please do the methemoglobin level. So third one is 5-year-old child with a recurrent respiratory infection. Echo is completely normal. HRAD treatment is hyperreactive treatment is given, not improved, given the multiple doses of bronchodilators. So multiple levels of bronchodilators. Dr. Abhijit, can you please switch off your mic, please?
Madam, please mute करा बाकीच्यांना.
So this is a child, we are a 5-year-old child. He is having the recurrent respiratory infections, and the echo has been done completely. It was normal, given the significant bronchodilator, different puffs, higher levels, steroids, not improved. And then again referred for echocardiography. And echo shows one pulmonary vein. Out of all 4 pulmonary veins, one pulmonary vein is going into the SVC, and that's how we have diagnosed this patient. And we did a CT scan and the limited MRI. Now the question is whether for one pulmonary vein, whether you require a surgery or not to require a surgery. That is most important, because the relatives will ask, for one pulmonary vein, is the surgery is recommended? So that is the reason we did a MRI, which proved the QP by QS, the relatively shunt from the single pulmonary vein, and we feel that single pulmonary vein causing a 1.3:1 shunt and causing a more symptoms. And we did the rerouting of the right upper pulmonary vein to the LA, and the surgery has been performed, and the baby is completely off any bronchodilator, steroids, inhaler treatment, completely well, and no issues at all. So single pulmonary vein also is important in our practice in echocardiography as well. So this is a 3-month-old baby, history of upper respiratory infections, developed distress, admitted in the hospital. X-ray shows a significant cardiomegaly. And you label this thing, you refer for echocardiography, and someone has seen as a diagnosis as a dilated cardiomyopathy. So dilated cardiomyopathy, I think everyone has seen. Dilated cardiomyopathy should be a diagnosis of exclusion. There should not have a coarctation. There should not have any stenotic lesions. There should not have any alkappa, and that is how there should not have any arrhythmia as well. So that is the reason dilated cardiomyopathy should be diagnosis of exclusion. So this echo has been done some other center, and they labeled as dilated cardiomyopathy, and the only the cardiac transplant was the only option given to the child, which is not possible at all 3 months of kid. So again, we come to our center, we did the echo, we have a suspicion of alkappa. So whenever there is a suspicion of alkappa, abnormal left coronary artery from the pulmonary artery, we did the CT scan, and it confirmed that this alkappa is present, and the open heart surgery has been performed, and the child is now 1 year old, is doing completely fine, with the ejection fraction improved from 20% to the 50 to 56% right now, but maybe it will improve over the period of time. So do not miss Al-Kappa in a dilated cardiomyopathy. Whenever the DCM report come in front of you, see whether there should not be written the coarctation, coronaries has to be normal. Then then you accept the report of dilated cardiomyopathy from the patient. So this is the 8-year-old child, cyanosis, dyspnea on exertion, saturation of 85%. Echo shows severe pulmonary artery hypertension, idiopathic or secondary. There is no shunt at all. It is idiopathic pulmonary artery hypertension in an 8-year-old child, saturation of 85%. There was a history of snoring. There was a history of snoring, and we did the CT scan, ENT examination. CT scan shows a significantly enlarged adenoids, chronic hypoxia giving rise to pulmonary artery hypertension. And do you know this? While doing the CT scan, this patient has arrested because in the CT scan, and he has to be intubated during that period of time. And because of significantly large adenoids, he was having a severe pulmonary artery hypertension. Then we perform his adenoidectomy, and after that, we slowly taper his pulmonary vasodilators. Now the child is doing good. So in echocardiography, history is most important. Whenever we come in echocardiography, the patient has a high pulmonary artery hypertension. I always, whether there is history of snoring is present or not present, any history of recurrent respiratory infection is present or not present, any history of a long-standing cold is present or not present. So that is most important history we have to ask from the echocardiography point of view as well as from cardiac point of view as well. So this is another kit, 7-year-old kid, complete of dyspnea, saturation 90%. Echo shows the moderate pulmonary artery hypertension, no structural heart disease. Respiratory system has an issue. They went to the pediatric pulmonologist. They did a bronchoscopy. They evaluated completely. And after that, we also investigated from the idiopathic pulmonary artery hypertension point, but we didn't got any other thing, and we labeled it as a idiopathic PH. But they sent the immunoglobulin levels, and they found the pigeon IgG was present. The child was exposed to the pigeon in the nearby areas. Their windows has been with the pigeon. They have some contact with to them, and this is the first case we had the pigeon exposure because of the child having got a pulmonary artery hypertension, respiratory issues, and now we have given the pulmonary vasodilators and steroids. Over the period of time, the steroids has been decreased. Now the child is improving. This is my first case, the pigeon exposure giving rise to pulmonary artery hypertension in practice. So it is symptomatic improvement is still is there. Still the child is completely not well, but it has recovered 50% than the before. So this is another very interesting kit. A 10-year-old patient admitted for some orthopedic surgery. Evaluation hypertension was 210 and 150. Unfortunately, they did the echo at that center, and some other person did, and it found to be a normal echocardiography. Ortho surgeries did well, but the prolonged healing time for that particular surgery. But the child was on the 5 antihypertensives. Then some my intensivist, after the patient discharged from the orthopedic surgery, sent for my opinion. And on my this thing, I have seen this is a CT picture. This patient is abdominal aorta. Can you see the patient has a significant abdominal coarctation? Whenever the patient come to my OPD, I always check the femoral pulse of the patient, because checking this femoral pulse, I have diagnosed or rule out so many DCMs, because it was found to have the Takasai's arthritis, having the abdominal coarctation. So this patient was sent for a CT scan after the echocardiography. His abdominal coarctation was present. The aorta at the abdominal level is significantly stenotic, and we did the CT scan, and CT scan proved it is a case of Takasai's arthritis, absent of bilateral femoral pulses. And because of this absent of bilateral femoral pulse and Takasai's arthritis, the child's BP was significantly on the higher side. So now the question is, you can see the angiography of this patient. We did the opinion of pediatric rheumatologist. ESR CRP has come down. We've given the cyclophosphamide, all this management from the rheumatic point of view, and it shows the significant abdominal coarctation. Only 1 millimeter size of the coarctation in a 10-year-old child. So we did the balloon dilatation of this patient, because stenting wasn't possible because very high chances of thrombosis. So we did the balloon dilatation, and after the balloon dilatation, the child did well. You can see his angiography now. It has improved from before. The BP has come down. Our next plan to put a stent across this thing once we are comfortable with, because Here, the lot of lesions, celiac axis come from that. If this aorta ruptures, we cannot put the covered stent because otherwise we'll block the mesenteric arteries and everything celiac trunk, and it is a completely catastrophic event. So the balloon dilatation was much more safer option, and we did that. Once we comfortable, we go for a stenting. So this now of 3 inotropes, the current BP is 140/90. Simple palpation of femoral pulses can get this diagnosis up to this level. So this is the last case. Only 2 minutes. I'm going to finish my talk. The preterm baby, 580 gram baby, is born in the Pune in KM hospital. Is a 23-year-old baby, which is smallest baby up till now. This cross all hurdles of prematurity, now become the 3-month-old with a weight of 1200 gram. He has all complications of NEC, laparoscopy, perforation, n number of BPD. All these things were developed in the baby because the baby wasn't stable. So on echocardiography, it was having the 2.8 millimeter PDA with left to right shunt and dilated LLB. This was our first case of premature PDA device closure in Pune because was fighting for 3 months from the 580 gram baby. They were not very comfortable for going for the another intervention, another risk of the thing. But we have convinced them they have to go for a PDA closure. So we did this is the echo picture. We can see the big size fetal type PDA in the premature baby. So we did the access of 1.2 kilo baby with all the coronary wire from the left side. So this angiography picture we have taken shows a very large PDA, 2.8 millimeter PDA in 1200 gram baby. We did the premature PDA device closure that is called as a piccolo device closure in this patient. And after this, we did 4 patients of premature PDA device closure in Pune. So after the device closure, you can see the device is well set across that PDA. And this is a small baby because the baby was on high frequency ventilation because of the PDA. It was not tolerating the conventional ventilation. It was on the high frequency ventilation. And that's the reason after that thing, this is my team. I think no effort can be completed without a team unless until you have a big team. It is not possible. It is a complete team efforts. My job is only 10 or 20%. The rest of the job done by all my staff, anesthetists, all the neonatologists who are managing this patient. So this is at the time of discharge. Okay, so premature PDA device closures are also very new things in the is a very challenging cases. So we completed more than 5,000 device closures up till now in the city of Pune without a single mortality. So device closure method is one of the safest option. We have treated our smallest babies 1.2 kilos up to the adult interventions also we do, including ventricular septal ruptures in the myocardial infarctions. Okay, so take home message is only 3 steps from my side. We should know heart disease well because the eyes will see, only the mind knows. So you should thorough with your heart diseases, and the basic crisp point of each and every heart disease has to be pinpoint on your mind. Suspicion of disease is important. You have to have suspicion, then and then you will refer for the cardiologist. Then and then you will have a refer for the any pulmonologist or any other thing, or at least do the X-ray. Whenever you are in a doubt, please do a pulse oximeter and X-ray chest of the patient. Because what I have seen in last 5 to 10 years, the number of X-rays advised in the OPD practice has gone down. And I feel whenever you are in doubt, when the child comes for a second time or not improving cough and cold, please do the pulse oximeter and at least do a 1 X-ray. So that will most of the time rule out most of the difficult cardiac heart disease, because dilated cardiomyopathy will have a large cardiomegaly on the X-ray, no murmur at all, and have a significant tachycardia. You will miss dilated cardiomyopathy because of significant tachycardia, because you will feel that the child has tachycardia because he's crying, or child has a tachycardia because you are given the bronchodilators. So we come so many times under neglect significant tachycardia in the patient. We are happy with the tachycardia, but we are not happy with the bradycardia. In adult scenario, they are not happy with the tachycardia, and the adult cardiologist is not happy with the they are not happy with the tachycardia, but happy with the bradycardia. But from the pediatric cardiologist, if my patient heart rate is 140, I am happy in the cath lab. But my patient heart rate dropped down to 90, I will get worried. So that is the reason tachycardia we take for granted, but that should be with the pinch of salt. And detailed history is an art and very important. History of snoring, adenotomy. Palpation of humeral pulses, very important. At least ask to the patient whether your child has leg pains or not pains. Because we check the femoral pulse at the time of birth and we do not check femoral times after that. At least 1 year 3 year and 5 year, that dictum has to be there for checking the femoral pulses of the patient. Okay, I think I finished my talk within a short period of time. This is our one of the interesting talk in a foundation course in pediatric cardiology. We have taken these courses across Maharashtra. More than 1,500 pediatricians attended it. We have the complete ECG discussion, 1 hour ECG discussion with all the ECG strips we give to each and every delegate, and everyone is very happy with this course. Over the period of time, I request Maharashtra IIP as well, Amol and our Joshi sir, we should conduct such a foundation course, dedicated course, 9 to 5 course, if everything appears suitable. Thank you so much for giving me an opportunity. Hope I finish my talk within 10 to 15 minutes. Thank you so much.
Yes, Pankaj. Very nice and very good cases. Everybody is zoomed to your presentation. Almost it is 10:40 and almost more than 50 to 100 pediatricians are still online. 50 pediatricians are still online.
The last 2 hours has given to me for 50 runs. I think I have to finish it.
I know you can talk for 9 to 5 constantly. You have completed talk in very good time. Yes. I think there are no questions in this one chat box. Ma'am, any questions are there?
No, sir.
Yes. Any questions from audience? They can directly ask also. So already it is 10:45. So just I would like to thank all pediatricians who have joined online and also those who are going to join tomorrow on YouTube videos also. This video will be uploaded on our MAHA sites. So please see this video. I like to thank Dr. Sanjay Joshi sir, Dr. Renu madam, Dr. Amol, Dr. Vinayak Patil, all office bearers and EB members of MAHA and IIP, Central IIP. Nothing from our sides. If there are no questions, we can conclude the meeting.
We have just 1 or 2 minutes for one.
Yeah, you can have 1 or 2. Don't feel.
Pankaj sir, I am very interested about that pigeon, the patient who was exposed to the pigeon and the pH. So can you just tell how much time, what was the age? I missed that. What was the age? And
the child was 10-year-old. That is a female child, 10-year-old. He was having a dyspnea on exertion, somewhat saying some sort of murmur because the thin-built old child. So whenever they get a murmur, the relatives are not very happy, complete dyspnea on exertion, and then they referred for because of murmur to me.
Yeah. So how much time the exposure was there, and like
the time of the exposure is approximately 1 to 2 years for that patient.
Okay.
Because that history, I didn't ask the pigeon history. I didn't ask the pigeon history.
Yeah,
actually.
obviously.
But I did the echocardiography, showed the moderate pulmonary artery hypertension, and initially we see all the this thing as we can say SLE and all these things, HIV, HbCG, and all this sort of the investigation we have sent for the patient, everything normal, and then I said, can you do a open up pediatric pulmonologist? So pulmonologist, I said some maybe respiratory disease, interstitial lung disease, or any other things which can't be diagnosed from my side. So pediatric pulmonology did a bronchoscopy, they found something abnormal, then they referred so many things, and then the pigeon exposure IgG as they've been advised, and it is strongly positive, very strongly positive. So this is the first of my case, like a pigeon exposure. Up till now I was reading in the paper only, but the patient was sitting in front of my eyes now. So then the reason I also learned how the exposure and this exposure will be asked by me in all my next pulmonary artery hypertension patients.
Yeah, definitely. Very good learning point. Thank you, sir.
Thank you.
Yes. Any comments or any questions? Sanjay Joshi sir, can we conclude? Renu madam?
Yes,
we can conclude. I think so. All the 3 of our participants have done a very excellent job, right from Dr. Sangamesh to Dr. Parihar sir and Dr. Pankaj. Very interesting topic until now at 10:45. Many people are there online, and without any MMC also they are seeing this program. And for next time we will try to get the MMC points also. So thank you all of you, and thank you Kundan for your excellent moderation.
Thank you.
And
Heartiest congratulations to all the 3 presenters.
Thank you, sir.
You were very crisp and precise, and messages were very clear cut.
Yes.
Especially, I really like the plethora of cases which were presented. Very nice.
Thank you, sir. Thank you so much.
Yes,
Thank
sir.
you. Good night to all now.
Good night.
Yes, sir. Good night. Sir. Yes, sir.
yeah, good night
Thank
all.
you, Kundan. Good night.
Yes. Chalo, good night, sir.
Kundan is
Good
still
night,
fresh.
Sushma madam.
Good night, sir.